Also, for the duration of the session, I would request all participants to keep their voices muted so that the speaker isn't interrupted. Thank you. We'll just begin in 3 minutes. All right, so we would be beginning with the session now. Um, Dr. Vivekanandan, sir, are you there?
Yeah, pretty much.
Great, sir. So we're ready to begin.
Yeah.
So, good evening, everyone. Welcome to day 2 of DefeatHep, the workshop by Project Pact Protect of the Public Health and Research Department of AMSA India. After an absolutely incredible session on the 20th, we have with us again eminent hepatobiliary and liver transplant surgeon, researcher, and managing trustee of the Chennai Liver Foundation, which is an organization associated with the World Hepatitis Alliance. Dr. Vivekanandan, and today to speak on liver transplantation for viral hepatitis. So this is right up your alley, and we're looking forward to an incredible session today. And I'm certain that all of us will find the session extremely interesting and we'll enjoy it thoroughly. The stage is all yours, sir.
You're trying to pressurize me, yeah? Okie dokie. So, right, can you see my screen?
Yes, sir, we can.
Okay. Right, let me just see myself first. Okay, there we are. So, I mean, yes, of course, transplantation is one of my favorite things, and I've been in it for some time now. So we've only got medical students here, right? I mean, as in
Yes, sir. All MBBS students.
undergrad, right?
Yes, sir.
So what I thought was that I would take this opportunity and give you some basics in liver transplantation. What are the indications, contraindications, why we should be doing it? Because once the liver is cirrhotic, be it alcoholic liver disease or viral hepatitis or NASH cirrhosis, the process of transplantation is the same. Okay, so Of course, there are a few changes with viral hepatitis and transplantation. I shall share that with you. But I thought I'll just take this opportunity and share some common knowledge about transplantation, which all of you guys should know and which would be certainly useful, or I think it would be useful. So, slide one, there we are. Okay, so why should we do a transplantation? Okay, what are the goals of liver transplantation? Okay, primarily it is to provide a better quality of life. That is the first statement which you should be aware of. I would not transplant someone who would who's on a deathbed. I would not transplant someone who's completely paralyzed and who's like a vegetable on a in a bed all the time. So you would not achieve anything by doing a transplant. So the quality of life needs to change, and at the same time, it needs to provide a longevity of life. So the first question people ask me is, so how long will someone live? Okay, so you need to know that the liver is an immunologically privileged organ, and if I were to transplant someone at 50 years of age, then I would say that you would live your biological age. Okay, so if they were destined to live till 80 years of age, plus or minus 1 or 2 years here and there, they would live at least 75 plus years. If they have a good follow up, and if they're managed very well in the post operative period. Okay. And of course, the third question which people ask me is, so can we be normal? Okay, there are enough people I've seen, enough people whom I've dealt with very closely who've gone back to their completely normal life. We transplanted farmers, auto drivers, priests, politicians, so on and so forth. So all of them get back to their normal life. Of course, some precaution is required. I could be slightly biased in saying I select my patients while I transplant them based on their socioeconomic status. That's simply because when you put in a lot of money and you waste an organ in transplanting, you may not be able to pick up a patient on the street, transplant them, and put it back on the street. That will be a waste of resource, right? So you need to make sure that there is some social background to the patients, so that they can function normally and get back to their normal life. Okay, so before transplanting, the question we ask ourselves is, can the patient survive a transplant? Right. So if I see a patient today in the clinic after counseling, I would say you need to go through an assessment. It's a very rigorous assessment. Predominantly, we focus on the cardiorespiratory issues. Make sure the heart is okay, make sure the lungs are okay. We do a lot of stress testing in people with diabetes for over a long period of time. Make sure there's an angiogram to make sure the coronaries are really good. Okay, so that is extremely important. The assessment part of it. If they're not fit, then we should not be transplanting the patients. And we transplant surgeons have an unwritten rule where we train or something.
I'm sorry for the disturbance, sir. Can all participants please switch off their audio and mute themselves so that we don't interrupt the speaker? Thank you so much.
Okay. So where was I? I forgot that. So yeah, so we make sure that the heart and lungs withstand. There's definitely a train going somewhere nearby, right? So we make sure that that they would withstand a transplantation. So we surgeons have an unwritten rule where the survival needs to be at least 50% for 5 years. If it's anything less, then we would not be offering a transplantation. So today the survival is amazing. It's quite extraordinary. It's far better than many of the oncological procedures which we do. For example, when we do a Whipple surgery of the pancreas, the 5-year survival is only close to 40%. Okay, but still we do it. While a transplant, a 5-year survival is close to 75%, and a 10-year survival is close to 70%. So the overall survival, so when I say success in a transplant, we have to measure it in 1 year, 3 years, and 5 years. Success in transplant does not mean getting out of the operating theater alive. Okay, so that is quite important. So you have to know that in a well-selected patient, the 1 year survival is 90%, the 3 year survival is 80%, and the 5 year survival is close to 75%. So, what are the common indications for transplantation? Acute liver failure. Of course, I'm not going to go into great details of any of these things. I'm just going to give a bird's eye view of the whole process of transplantation. You can always read all these things in the books. So, acute liver failure is when the liver fails suddenly, all of a sudden, within 24 hours time. Okay. Chronic liver disease, when it's associated with cirrhosis. I think last time itself I mentioned that most of the liver cancers happen in a cirrhotic background. So, hepatocellular carcinoma in a cirrhotic background, the best form of treatment is a liver transplantation. And there are n number of metabolic problems, Gaucher's disease, familial adenosis polyposis. Sorry, not familial polyposis, it's familial amyloid polyneuropathy, Niemann-Pick disease, so on and so forth, which do not have cirrhosis at all. They never decompensate, but they do have various problems for which a transplant needs to be done. So acute liver failure, multiple causes of acute liver failure. I'm not going to go through all of that. I think in our country, what we have seen is an acute hepatitis B can cause acute liver failure. I'm not sure of northern India though, but southern India, we have seen quite a bit of rat killer poisons. The yellow phosphorus rat killer poison is a very, very potent suicidal drug, and we've seen enough number of liver failures secondary to that. Of course, paracetamol can cause liver failure, but again, that needs to be above 12 to 15 grams. We've seen anti-tuberculous drugs causing liver failure. We've seen pregnancy-induced liver failure, where a lot of fat accumulates in the liver, and acute fatty liver of pregnancy, acute autoimmune hepatitis, acute Wilson's, so on and so forth. So a lot of causes for liver failure. So there are two significant, or maybe three significant features that happen in acute liver failure. One is jaundice, very, very quickly. Second is hepatic encephalopathy, where the serum ammonia levels raises and it clouds the brain, and the patient becomes first semi-conscious and later unconscious, and a raise in your PT-INR. Okay, so these are three characteristics of acute liver failure. So whenever you see someone who's acutely jaundice, you have to do a serum ammonia level, a complete liver function test, along with an INR, and that will give you a clear picture. One important distinguishing feature between ALF and chronic liver disease is in ALF, or acute liver failure, the SGOT-PT is remarkably raised. It's in the thousands, 2,000, 3,000, 4,000, because the liver is very necrotic, and when the liver cells die, they release the enzymes, and hence the OTPT is very high, and so is the ammonia level and the bilirubin level. While in chronic liver disease, you don't see a raise in SGOT, SGPT, because the cells have all been replaced with fibrous scar tissue in cirrhosis. So you don't see a raise in SGOT-PT, but you see a decrease in your albumin, a slow increase in INR, and a slow increase in your bilirubin. So do we transplant all patients who've got acute liver failure? No is the answer. We use certain criteria. This criteria is called the King's College criteria. Okay, or it's a kind of a modified King's College criteria. It's been validated, and it's been there for a fair bit of time now. So if anyone fulfills 3 out of the 5 criteria that I've mentioned here, then obviously they should be listed for transplantation, because evidence today suggests that if you're not transplanting, if they fulfill the criteria, then the patients don't do very well. So age less than 10, more than 40, jaundice to encephalopathy more than 7 days, non-A, non-B means it's non-hepatitis A or non-hepatitis B, bilirubin more than 17, and a PT-INR of more than 3.5. So this is a classically looking acute liver failure liver. The liver is extremely stiff. It's very pale to look at. There are absolutely no nodules. It's very smooth, but certainly very, very stiff. And when you biopsy these livers, there'll be a lot of necrotic tissue in these livers. So this is how an acute liver failure liver would look like at laparotomy. So next we move on to chronic liver disease. So chronic liver disease means it's cirrhosis. And what is cirrhosis? It's the end stage of any chronic liver disease. Okay, cirrhosis takes many years to develop. Okay, it takes more than 15-20 years for the liver to become fibrosis and then become cirrhotic. So what classically happens is there are lots of regenerative nodules and fibrous tissues is formed within the hepatic plate. Okay, and then the liver starts to shrink. So when you see a scan, an ultrasound scan or a CT scan, what happens is the liver is getting smaller and smaller by the day in cirrhosis. That is because the scar tissue or the fibrotic tissue within the liver pulls itself inside. So when it pulls itself inside, it shrinks over a period of time. So there are two types of cirrhosis: compensated cirrhosis and decompensated cirrhosis. So when I say compensated, patients you would image these patients, and a CT will show a cirrhotic liver, an ultrasound will show a cirrhotic liver, but they will not have any symptoms at all. No pedal edema, no jaundice, no bleeding, no ascites, and the LFTs will be reasonably within normal limits. This is what we call compensated cirrhosis. So in cirrhosis, what is important is the functioning of the liver rather than the structure of that liver. So you need to make sure the LFTs are good, and you need to make sure the symptoms, he doesn't have much symptoms of liver disease. But when certain symptoms happen, which I will come to shortly, we call it decompensated liver disease. So this is how an alcoholic cirrhotic liver will look like. Alcoholic cirrhotic liver causes micronodular cirrhosis. Tiny nodules happen, while, for example, Wilson's disease will cause macronodular cirrhosis. There will be big nodules on that liver. Okay, the liver is again firm and hard. A lot of nodules are there, but still it will be reasonably functioning well, because it's been happening over a very long period of time, and so the body would have adapted itself. But this is how a cirrhotic liver would look like. So what's a natural history of the disease? So I did mention that two stages: one is compensated and one is decompensated. Okay, so cirrhosis normally represents the end of histological stage, resulting in chronic liver injury of various etiologies. Okay, the transition to a decompensated state is marked by the development of any of the 5 complications which are mentioned there. One is varicose hemorrhage, which means they either vomit blood or they pass black stools, which is melena. Black stools because when acid acts with the blood, it turns into black in color, and that's why when they pass stools, it's black in color. Okay, so that's called melena. And when someone's got melena, it means that there's a GI bleed. And someone develops ascites. Even the smallest form of ascites is called decompensated liver disease. Encephalopathy, documented encephalopathy, meaning that someone's talking funnily, or talking irrelevantly, or loss of sleep pattern, altered sleep pattern. They tend to sleep during the daytime, but being awake during the nighttime. Then, of course, semi-consciousness and unconsciousness. There are lots of grades in encephalopathy, which will be marked with an increase in serum ammonia level. Okay, and of course, jaundice causing an increased serum bilirubin, and HRS means hepatorenal syndrome. So, what's hepatorenal syndrome? Where when in a cirrhotic liver, lots of chemicals are released, which causes vasoconstriction of the kidneys. And when the kidney vasoconstricts, what happens is blood flow to the kidney decreases, and when it decreases, it doesn't function very well. So how do you know? The creatinine will go up. Okay, and there are wonderful medications to completely reverse this these days. So there's 2 types of HRS: type 1, type 2. But you should know that in any patient with the liver disease, it's quite essential that when we do a blood test, we have to do a kidney test also at the same time. You have to do a complete liver function test, you have to do an INR, and you have to do a renal function test. Why? Because we have to understand whether the kidneys are getting blocked, or when I say blocked, the kidneys are getting injured or not. So you have to look at the creatinine level, so hepatorenal syndrome. So that is the stage when patient develops any of these complications. That is the stage when we say that the patient moves from a compensated state to a decompensated state. Of course, if left untreated, then obviously death happens. There are very, very few conditions where patients can move from a decompensated state to a recompensated state, okay, which means they go back to a compensated state. That is, for example, alcoholic liver disease. Okay, so when people have been drinking heavily, and then you see them at somewhere at this stage, okay, and you ask them to stop drinking, and they might go back to this stage, provided the liver is not too cirrhotic. Okay, so that is why we never transplant patients with alcoholic liver disease straight away. We ask them to wait for 6 months at least to see if they would of course they would show that they can stop drinking, to whether we can get them back to the recompensated state. So it's quite essential that we wait in alcoholic liver disease and not transplant these patients straight away. So this is the natural history of chronic liver disease. Now, two major things happen in cirrhosis. Okay, one is called a synthetic failure of the liver, and the other is portal hypertension. Okay, and when the liver becomes cirrhotic, okay, it hardens, and then you should, if you remember your anatomy, the splenic vein and the portal vein join together and go into that liver. And when something hard is sitting in the path of that blood vessel, then there is a resistance of forward flow into the liver. So the portal flow cannot get into that liver. Hence, what happens? It comes back into the splenic vein and into the intestines. And when it comes back into the splenic vein, it goes and gets lodged in the spleen, and the spleen starts to enlarge. And that is why you get splenomegaly and cirrhosis. And when the spleen starts to enlarge and blood goes through into the sinusoids of the spleen, the platelets get trapped. Okay, and that is why you get a thrombocytopenia in cirrhosis. Even today, I've seen enough number of doctors do bone marrow biopsies, this, that, to understand why there's thrombocytopenia in cirrhotic patients. So that is because of portal hypertension. The other features of portal hypertension is, of course, varicose hemorrhage, ascites, and of course, encephalopathy can also cause portal hypertension. It also causes a pure synthetic failure of that liver. When I see synthetic failure, it's complete liver insufficiency, where vitamin K induced factors are not produced, bilirubin is non-metabolized, causing jaundice, and of course, albumin is not being synthesized in that liver. So if I were to see someone with an albumin of 2.5, with a bilirubin of 2 or 3, and an high INR of 1.5 to 2 or something like that, and the ultrasound or the CT shows a cirrhotic liver, I would say we should transplant these patients, because never ever you're going to reverse any of these conditions. I know I said about recompensation, but when there's a core synthetic failure, recompensation may not happen. So I think transplantation is quite essential in any of these patients. So why should you transplant decompensated patients? It's because of the right-sided two columns. Okay, so when they're in decompensated state, which means either they have ascites or varices or bleeding, so on and so forth, the death rate at the end of 1 year is close to 20 to 60%, depending on the stage of the disease. So it's quite important that we differentiate between compensated and decompensated. And also, we know that patients with cirrhosis can live a normal life for a very long time. As I said, well-compensated patients will be surviving very well for many, many years. But once they decompensate, they really drop off. And if you can see this Kaplan-Meier curve, the survival is dramatically reduced. So when do we transplant these patients? We see acute liver failures, we see chronic liver failures. So when do we transplant these patients? So we have a selection criteria for transplanting these patients. Okay, so if and when they decompensate, or I'm sure you've heard of the child scoring system, MEL score, which I will come to in shortly. And as I said, HCC, we transplant patients with HCCs, so they either get the Milan or the extended Milan criteria. PEL means pediatric end-stage liver disease score. So I'm going to touch upon this very, very briefly. Okay. Of course, decompensation, I've already told you about these things: encephalopathy, refractory ascites, variceal bleed, spontaneous bacterial peritonitis. Anyone with ascites, the ascites need and sent to be analyzed to see if there's any infection in it. A raised white cell count of more than 250 in an ascitic tap means it's called spontaneous bacterial peritonitis, and that is a complication of chronic liver disease, and that is a good indication for transplantation. And as I said, poor synthetic function. Okay, child's criteria, child's A, B, and C. You can look up all the components of the child criteria. I'm not going to go into those details, but definitely a child C patient or anyone between from late child's B to early child C patient should be offered a transplant, because the 1 year survival without a transplant is close to only 35%. So that's quite essential. We calculate the child's criteria. But again, child's criteria is a very clinical criteria, very subjective criteria. So nowadays we use the MEL score, or the model for end-stage liver disease. Okay. So when you see a liver patient, you have to, as I said earlier, you have to do a liver function test, you have to do an iron test, and you have to do an INR. And with that, there is an online scoring system called the MEL score, MELD. Okay. MEL score ranges from
I'm sorry, sir. Can whoever's speaking, please shut off their audio? Thank you. Yes, go ahead. I'm sorry.
Sorry. So MEL score ranges from 6 to 40. 6 being a normal and 40 being a supremely sick patient. And when the MEL score crosses 15, there is a clear evidence that these patients would need a transplant. So this is more objective, and it's not a subjective scoring system. So this is based on the actual blood test of the patient. So this is a better scoring system to understand whether the patient needs a transplant. Oops, who's muted me? Can you hear me?
Yes, sir, we can hear you. Your voice just went off momentarily.
Okay, I'm good. So it predicts survival, and also it's used in the organ allocation process. So when the MELD is 20 or 25, then I would want to transplant these patients earlier rather than later. So I use this criteria to transplant to assess as to when the patients would be given a liver. Because I'm not going to go into great details about transplantation for HCC, but do understand that size matters. So we can only transplant patients when the tumor is of certain size. Okay, it has to be either under 5 centimeters as a single tumor, or under 3 centimeters up to 3 tumors. Of course, this is called the Milan criteria. This was published, I think, way back in 1996 or something, but it still really stood the test of time. Because we've slightly extended beyond now. Most of us in India use a UCSF criteria, or the University of California San Francisco criteria, where a single tumor of up to 7.5 centimeters or 3 tumors up to 4.5 centimeters each can be transplanted. What is important is they should not have any vascular invasion, i.e. portal vein invasion or an hepatic vein invasion, and they cannot have any extra hepatic disease. If it's well within the liver, then we jolly well can transplant these patients, and you can cure the cirrhosis, and you can cure the cancer with the transplant. So that's quite important. So transplants, so HCC should be picked up early for us to cure these patients. So those are the I didn't go through the indications of transplant. Of course, as I said, alcohol being the most common cause in our country. Second being fatty liver disease turned into NASH, into cirrhosis. Or the NASH cirrhosis. That is the second most common cause in our country. Third probably is viral hepatitis. Fourth is metabolic, most commonly Wilson's. And fifth comes whole lot of diseases. So when do we not transplant these patients? Okay, if the patient is brain dead, recipient can be brain dead. For example, an acute liver failure patient can have coning, and the brainstem can get injured. And when the pupils are fixed and dilated, you don't transplant these patients because they don't wake up after transplant. When there is extra hepatic malignancy, if there's a history of breast cancer, history of colonic cancer, history of even skin cancer, we won't transplant these patients. Obviously, if it's happened 10 years ago, then that's a different thing. But anything in the near recent past, obviously we would not transplant these patients. Uncontrolled sepsis, active alcohol abuse, as I said, severe cardiopulmonary disease. The heart and lungs need to be pristine. If not, we will never transplant these patients. And of course, as I said earlier, lack of social support. There needs to be a family that once you transplant these patients, they should be able to go back to a reasonably safe house, with a reasonably good family, and so they can at least buy their immune suppression, have clean food and clean water. Otherwise, it will be a complete waste of time. Of course, there are lots of relative contraindications. Age. I personally would transplant up to 70 years of age, and that's what anyone in UK would do. In India, there has been a few centers who've been doing transplants for 72, 75. Now, I don't believe that is the right thing to do. So it's simply a center preference. So, but I think 70 is a good age. Cholangiocarcinoma. I told you HCCs can be transplanted, but cholangiocarcinomas are carcinomas that happen in the bile duct of that liver. HCCs is coming from the hepatocytes of that liver. Okay, so there's only one unit in the whole world who transplant for cholangiocarcinoma. They have some amazing results, and that is the Mayo Clinic. No one else has been able to replicate their results, but maybe in the future we might start doing those things. But as of now, we do not transplant for cholangiocarcinomas. Portal thrombosis again is a very relative contraindication. As your skill increases, you should be able to do a thrombectomy and remove the thrombus and transplant. Renal failure is not a major issue these days. Again, coronary artery disease or HIV is not a contraindication at all for transplantation. We should be able to deal with this without a major problem. So, of course, a few slides on the actual topic itself. As I said, viral hepatitis probably in our country is the third most common cause for cirrhosis, and I think in the next few years, maybe, when I say a few years, it's going to take a decade at least, I think, for our vaccination to catch up. And of course, hepatitis C is going to be completely eliminated or completely curable these days with those amazing antiviral drugs. So I think at least in India, viral hepatitis will be eliminated in the next 10 years. But I've seen, I've been to China, some amazing units in China and in Korea, where at least 40-50% of their work is related to hepatitis B. Okay, so hepatitis B in the Western world is completely gone. In fact, 40% of all transplants in the Western world, predominantly in the United States, is due to hepatitis C. Okay, because of the drug abuse, homosexual activity, so on and so forth. When it's associated with HIV, also co-infection with HIV. So hepatitis C is a huge problem in the Western world. But then again, with the direct acting antivirals, I think this is going to be completely go off over a period of time. But on the eastern side, especially China, Korea, Vietnam, Indonesia, so on and so forth, the problem is hepatitis B. Okay, in India, as I said, it's our prevalence rate is about 2%, and our hepatitis C prevalence rate is about 0.5 to 0.8%. It's not too high. So, but our B transplant only about 15-20% of our patients who have hepatitis, either B or C. Of course, hepatitis A or E can cause acute liver failures. Hepatitis, we know hepatitis A and E have come through the fecal-oral route. Okay, that is why we say drink clean water, eat clean food. Okay, and At times, the liver gets affected very, very rapidly. I think in the last 10 years of my existence in India, I think I've done at least 15 to 20 patients with either hepatitis A or E transplants. Okay, so it's a fair bit. The at least 1 to a year easily comes. At least even with my experience, I think with so many various other units put together, there'll be a fair bit of transplantation happening for hepatitis A and E. Of course, things have changed dramatically these days with the advent of antivirals. What's the indication in hepatitis B? Hepatitis B, as I said, vertical transmission normally doesn't produce cirrhosis because they detected very, very early. I think we spoke about vertical transmission 3-4 days ago. But when there is when they acquire the disease in their late teens or in the early 20s, they do not know that they've got the disease. So automatically, by the age of 50, the liver becomes completely cirrhotic. So that is one. When the liver becomes cirrhotic, we know that they can develop HCC. So HCC is in the criteria, is an indication for transplant and Hep B. And of course, acute hepatitis B can be caused by the B virus. And we've transplanted a few patients who've had acute Hep B or acute liver failure secondary to hepatitis B virus infection. As far as hepatitis C is concerned, as I said earlier, it is a leading cause of leading cause in the Western world for chronic liver disease. Okay, please remember that hepatitis C will not cause acute liver failure. It's hepatitis A, E, and B will cause acute liver failure. Hepatitis C will not present with as an acute liver failure. Okay, so if you would see a patient with Hep C, it almost always means that they've had this disease for the last 10 to 15 years. The second golden rule is that if a patient's got hepatitis C and you see a HCC, never go resect these patients, never do anything alternate, because it's always multifocal. Small tumors, multiple tumors happen in hepatitis C. So you always take the entire liver out and put a new liver or transplant these patients. Okay, as I said earlier, acute liver failure does not happen in hepatitis C. Okay, so about hepatitis B in the pre-transplant, intra-op, and the post-op period, what do we do? Pre-op, so anyone with cirrhosis secondary to viral hepatitis should be started on the respective antivirals. Okay, if it's B virus causing cirrhosis, whatever be even if the HPV DNA is less, they should be started on antivirals. And today the drug of choice is tenofovir alafenamide 25 milligrams, and they should be on it for lifelong. If not, the chance of cancer formation is extremely high. So anyone who's got heavy cirrhosis, they should be started on antivirals straight away. So intra-op, what do we do differently from any other transplant? Earlier days, we were giving immunoglobulins, Hep B immunoglobulins. We spoke about this again 3 days ago. Immunoglobulins are quite expensive. Okay, so once the entire liver comes out, okay, the patient, when in the anhepatic phase, is given the immunoglobulin, and when the new liver goes in, the new liver understands or thinks that the body's already got the antibodies and thinks that the patient does not have Hep B. We try and cheat the liver, but it doesn't work that way. So we've stopped using immunoglobulins. There's enough studies which have come out today to suggest that immunoglobulins is not required in the intra-op period. In fact, we give so much of immunoglobulin that it really adds up another 2-3 lakhs to the transplant process itself. Okay, then of course post-op, if someone's HPV positive, and even if their HPV DNA is completely negative or absent, then these patients should be on antivirals lifelong, unless they become HPV negative, which is very, very rare. It does happen a few times, but certainly antivirals should happen in the post-op period. So antivirals definitely in the pre-op period, antivirals definitely in the post-op period. Immunoglobulins in the intra-op period is a quite a debatable thing these days. So I would not use them, but still there are lots of units using heavy immunoglobulins. HCV and liver transplantation, pre-op, intra-op, and post-op management. Pre-op, again, and direct-acting antivirals is quite debatable. People say that, you know, if your child's A cirrhosis, okay, or early child's B cirrhosis, then you can have the antivirals because the liver can get better. All right, there's one group which do not treat any of these patients because they feel that the virus is definitely going to come back. You save this drug for the post-op period. Okay, so there's one group of transplant surgeons would give antivirals in the pre-op period. Of course, I don't do any antivirals in the pre-op period. We just transplant these patients, wait for the new liver to set in, and then give the antivirals in the post-op period. This only, I mean, we've only had these antivirals the last 3-4 years. Beautiful drugs which would completely eliminate the virus. So you might want to preserve these tablets until, you know, in the post-transplant period, because in the post-transplant period, when you get the virus again, then, you know, it's very difficult to manage these patients. So intra-op, no management, we don't give, there's no immunoglobulins for HC, and also we don't do anything different. So pre-op and post-op direct acting antivirals is required. So that's about viral hepatitis. So quickly to the types of transplantation, there's quite a big list of transplants which we can do. Orthotopic means putting the liver in its original position. You know, you can't put your liver in the right leg fossa. You can't put the liver in the retrogastric area. You can't put it in the left leg fossa. It has only one place to go because it's a big organ, right? So you have to take the entire liver out and put the new liver in. It's called orthotopic transplantation. It can be either a cadaveric transplant, a full liver, or a living donor liver transplant. You can reduce it. You know, if it doesn't fit, if a cadaveric liver doesn't fit into the cavity, you can reduce it. You can trim off the liver, and that's called a reduced graft. You can split the liver into two and give one liver to two different people. You know, that can happen. It's called split liver transplant. Next is auxiliary liver transplant. In certain metabolic conditions, what we do is, or in acute liver failures, what we do is, if so, for example, if patients someone's had a rat killer poison, you know, so it's affected that liver. Well, we remove half of the recipient's liver and put a half of the new liver in. Okay, and and what happens is this new liver tides over the crisis during the acute period, and then a year later we go in and remove the new liver, so the patient will survive on the old liver. So this is called auxiliary liver transplantation. It's a very novel process. Thereby, the patient will not have any immune suppression lifelong. Okay. Dual means putting two small grafts into one patient, and of course, combined liver kidney, as the name indicates, doing two transplants at the same time. Cadaveric transplantation, of course, the entire liver is taken and the new liver is put in. I do have some photographs. I shall share that with you. Of course, the retrieval matching. People ask me, what do you do? Do you do HLA matching for liver transplantation? It is not required. You only do need a size match and a blood group match. Of course, when you look at a beautiful liver like this, you know, this will fit into any abdomen. Small, the edges are sharp. It doesn't look too fatty to me. So we would happily, jolly well transplant these livers if there's a size match and a blood group match. Okay. Of course, another beautiful looking liver, nice sharp edges. The color is good. You know, so these livers are amenable for splitting. You know, you can comfortably split this liver into a right lobe and a left lobe, or an extended right lobe. So this is the falciform ligament. You remove 3/4 of that liver. So this can go into a pediatric patient, and this can go into an adult patient. This is splitting of that liver. So if you split it on the bench outside the body, it's called ex situ splitting. If you split it within the body and keep it resected and then remove it, it's called in situ splitting. So some operative photographs. Yeah, I think so. The head is on your left top corner. This is the leg end is here, and that is the IVC. So you're standing on the right side of the patient, and the liver is completely out. You know, now we do something called, hold on, what is this? No, go on, go away. Right. So we do something called hold on, what's happening? Are you guys seeing something else? Okay, there we are. So we do something called a piggyback technique. So we don't have to clamp the IVC. When you clamp the IVC, a venous return from the kidneys or rogered up. So that you protect the kidneys by doing something called a piggyback technique, where the IVC continuity is the same, and then we only transplant the hepatic veins, which probably is somewhere there. Okay, and then obviously that's a hepatic vein, and it's a bad picture, but nevertheless. The top end of the IVC, this brown, light brown was a donor liver. You should be able to anastomose the hepatic veins, and then you flush the liver, because the liver, this light brown is the liver, and this white part is called the portal vein. Okay, so the vena cava anastomosis is done, and then you flush the liver with some normal saline or dextrose or something. Why? Because you have to flush out all the preservative solution. Okay, so once you do that, and then you do the portal vein anastomosis. So that is the portal vein of the graft, and then I think probably this clamp is the portal vein, recipient portal vein, which you join. So that is joined somewhere there, and then that is the liver, which is ready to be perfused. Now it will look very pale, but then when you start perfusing, it turns to be pink. Okay, we call it a beefy pink. If the liver is good, then automatically within a few minutes, you'll be surprised to know that you'll start seeing bile. Like when you do a kidney transplant, you start seeing urine, you start seeing bile while doing a liver transplant, and then you're happy. Then you know that the patient is going to do very well because the liver is working. So once you do that, after that you do the arterial anastomosis. So the order of anastomosis is, first one is the vena cava anastomosis or the hepatic vein anastomosis. Second is the portal anastomosis. Third is the arterial anastomosis. Okay, because artery is important for the bile duct, so you have to do an arterial anastomosis. Why the portal anastomosis is done earlier is because the portal vein carries 70% of the blood supply. So you have to do the portal veins first. Okay, and then of course the last being the bile duct. Okay, that's the last anastomosis to be done. Okay, but there are lots of issues with cadaveric organs in our country. We don't have enough organs for transplantation. Quality of the organs is a huge problem. Donor maintenance is a huge problem. We are trying to standardize all these things. High waiting time. People drop off the waiting list while they're waiting. Hence, that is why we've started off with the living donor transplant. If you see, there is a huge divide between the eastern hemisphere and the western hemisphere. The West, everyone's into cadaveric transplantation, where the East, everyone's into living donor transplant. In India, I think we, on an average, all units put together, we probably will be doing about 2,500 transplants. China does a huge number, Korea does a huge number. So there are lots and lots of living donor transplants happening in our country. It's a lot of advantages, because it's planned surgery. You can there's no deterioration on the wait list. We can plan it very well. If there's a complication, if there's infection, you can still wait and you can transplant a week later or 10 days later. We pick and choose the best organ, so the graft function is very good. And at least I've seen that when you put a good quality liver in, there's a very short hospital stay. And we discharge patients in about 10 days time these days. So living donor transplant is far better. So who can donate? It has to be in a biocompatible blood group. In India, they have to be related. The donors, we say, has to be between 18 to 50. 18 because that's the age for consent. 50 because beyond which the liver, we believe, will not regenerate very well. So 18 to 50 is the age cutoff. Certainly, patients should not be a diabetic, because diabetes means fatty livers. Fatty livers means they don't regenerate very well. And of course, the donor cannot have any cardiorespiratory issues. We cannot lose a donor. The program will come to a grinding halt if you lose a donor. So you have to select your donors very well. Of course, we can do this because we understand the anatomy far better. Those guys who are in the first year, second year, or first years now, please learn your anatomy well. I don't think I did that very well. And I've learned a lot of anatomy as I was operating, but we used to fool around in the anatomy lab. But But I mean, that is an opportunity missed. So please don't miss that opportunity. Learn anatomy. If you have an opportunity, go back to the dissection theater, and I think you should do that. Take the liver in your hand, take the kidney in your hand, play around with it, so you'll understand it a lot better. So the coinoid segments, as you know, there are about 8 segments in that liver: 2, 3, 4, 5, 6, 7, 8. In a clockwise fashion. So an adult would require the right lobe, 5, 6, 7, and 8, because it's a big guy. Okay, and adolescent will require the left lobe. It's 2, 3, and 4, right? And while a pediatric patient will require a 2 and 3, right? So this is just a rough guide. But today there are amazing softwares which can reconstruct every bit of vessel, every artery, and every vein is reconstructed, and which segment to spare and which segment to protect. So this is how these are the quality of images which you can get today to understand the hepatic veins. So the green is the hepatic veins, and I think the red is the portal veins. Okay, I mean, this is reconstructed. These are real CT scan which is reconstructed. So the plane of transection, which one to divide and which one to protect. Okay, so of course that's a good looking liver that's completely divided. I think that is a middle hepatic vein. I'm not going to go into any details of that, but that is a living donor transplant in progress. Of course, we have to reconstruct, do a lot of bench work on reconstruction. Living donor transplant is a laborious process. It requires 2 teams, 2 theaters, 2 ICU beds, so on and so forth. But nevertheless, it's quite rewarding because patients do very well. Because that is your IVC. That is an iliac vein which is reconstructed partly for the hepatic veins, and I think your hilum will be somewhere there. Your bile ducts and arteries will be somewhere there. Okay, so then you plumb these vessels in. I don't understand what is this, but nevertheless, I'm going to skip that. Okay, so that is how an anastomosis, and that's the IVC actually. That's the IVC. That's half of a liver. That's the hepatic vein which is already joined, and I don't know if you can see that's the portal vein that's already joined. Okay, and that's how it will look like, and it will be interesting if you do a scan in about a month's time. Okay, the liver would have grown back. You need to understand that all livers will regenerate, and the rate of regeneration is it's close to 90% of its original size in 3 weeks' time. Will regenerate. Okay, of course, we're slowly coming. Last few slides. There are lots of myths about transplantation in our country. People all think it's all hanky-panky work. People think organs can be sold in the black market. People think that you can skip the queue. All those things cannot happen. There are enough laws and enough organizations in our country to police us, and they act as a big brother. And of course, the laws have gotten very strict these days. TOTA is the Human Organs Transplant Act that gives you exactly who should be transplanting, what are the laws, what's the paperwork that's required. Of course, Transplant is an organization in Tamil Nadu which monitors our transplant activity. Likewise, now every state has got their own organization, a governmental organization which controls the transplantation. Of course, the central government has given all these NOTO, ROTO, SOTO. That's the National Organ Transplant, organization, Transplant Authority, or something like that. Then this is a regional. Then this is a state. So TOTA gives these 3, and then individual states have got their own organization which polices as to what you do. To summarize, I think transplants change the quality of life. It's an amazing surgery. Anyone with cirrhosis should be given the opportunity for transplantation. When it's done early with a good quality life, the results are very good. And for that, I think early referral is the key. And as far as viral hepatitis is concerned, there's no contraindication at all. I think everyone should have a transplant. Hepatitis B, you should have antivirals before and after. Intra-op, I don't think you have to do anything. Hepatitis C, you should have your antivirals after the surgery. That's what I feel, and that's what I practice. I think this is I mean, I've got a 10-minute surgery. I'm going to skip that. If you guys want it, I can show that, but it's in about 7-minute edited video on transplantation, on the surgery itself. I'm going to skip that. If you want me to, I can do that. Yes or no? You don't have to be very what to say, politically right. You can say no. It's you just overshot. You're boring us already.
Yeah.
So you can always message, and I can show that. But otherwise, I'm going to say thank you.
So thank you so much for this presentation. I certainly felt that most of our participants would have been transported to the operation theater for the good duration of the surgery, for a good duration of your presentation. Some of our participants would want to see the 7-minute video. So what we can do is maybe we can share it on our YouTube, on our WhatsApp group for the event. We have some very interesting questions from our participants, so we could move ahead with that. Chishki?
I think the connection might be a bit slow, Parikshit. I'll take over from here. A few of our participants had some great questions for you, sir. I'll read them out and you can maybe answer them. Would that be okay?
Yeah, go on.
Great. Pragya Chand is asking if you could explain again why thrombocytopenia occurs in decompensated cirrhosis.
Okay, so in cirrhosis, the liver hardens. Okay, well, before that, we know that the portal vein enters the liver, correct? And then the liver gets get cleansed in that liver, and through the hepatic vein goes out to the kidney and the heart. Okay, but when the liver hardens, there is a forward resistance of flow. Okay, the blood cannot naturally enter into that liver because the liver is very hard. It prevents the blood from entering into that liver. Okay, and then so the blood goes back into the spleen. And when it goes back to the spleen is an end organ. The blood can't go anywhere beyond the spleen, right? And then the spleen starts to enlarge. And when the spleen starts to enlarge, the blood keeps circulating into the sinusoids, the platelets get trapped there. Okay, and that is why when you in non-cirrhotic patients, the platelets are very low. So when you do a splenic artery embolization, or when you tie off the splenic artery, okay, when the blood flow to the spleen is very less, no, the platelets drop is very, very slow. I hope I'm clear. So it's because the platelets are trapped in the spleen. The spleen is big because there's a backward of blood from the liver back into the spleen. The spleen gets bigger, platelets are trapped in the spleen.
Yeah, so the next question is, can an artificially cultured liver be an alternative to cadaveric liver during liver transplantation?
Nice question. That's called bioengineering. Okay, the problem with the livers is that we know that the liver's got over 500 different types of functions, and as of now, it's extremely difficult to mimic all those functions. But having said that, people are already working on it. They are developing livers in the lab with stem cells. You know, some palm-sized livers have already been produced. Wild eggs have been grown. So yes, it's all exciting times. You know, maybe you guys should think of bioengineering and so on and so forth. We started work on heart. Okay, they've grown kidneys in the lab. They've grown heart in the labs. They've grown small bits of liver in the lab. Okay, but we are far away from transplanting these organs. Maybe 10, 15 years away, I would have thought. But I think it should happen in our lifetime.
Definitely, so we can only hope so. Sarath is asking, at what age is it necessary to transplant the whole liver, and till what age can we assume that regeneration will take care in the cases of partial liver transplant?
No, I don't understand.
Would you like me to repeat that, sir?
I'm reading it. What is necessary to transplant the whole liver? So it does not, I mean, there's no age for a partial or a full transplant. Okay. Say, for example, in a pediatric, say, in a 4-month-old child, the most common cause in our country is biliary atresia, where the bile ducts or the extrahepatic bile ducts don't develop. Okay. In that case, we have to take that liver out and put a new liver in. Okay. So a 4-month-old child is probably 10-12 kilograms. Okay. You can't get a liver of that size and for a baby. For that, you ask the mother or the father to donate a part of a liver. Okay. So it all depends on the size of the patient. It all depends on the need of the patient. If the patient can wait, then you wait for a cadaveric liver. If the patient cannot wait, then we push for a living donor transplant. So regeneration will happen in every living donor transplant which we do. Okay, every patient, every liver will regenerate because we choose the most pristine livers. So age, we don't transplant full liver or half liver based on age. We transplant based on the size and of course the need and the necessity. Every liver will regenerate. A full liver will not regenerate. Full liver, it's got a capsule. It can't grow anywhere. It can't produce new lobes. It's only a half liver is going to grow.
We could possibly move to the next question.
Yeah, sorry, my network is a bit slow. I could still hear sir's voice. The next question is from Pranav. He's asking, usually SGPT levels rise in liver diseases, but why do we see a more prominent rise in levels of SGOT in alcohol-induced liver damage?
So, so SGOT and SGPT are two hepatocellular enzymes. Okay, that's ALT and AST. I don't. I have to say I can't answer that question because in acute alcoholic hepatitis there is a generalized increase in both the SGOT and SGPT. Okay. Of course, SGPT is more specific for that liver. Okay, the SGOT, but when you combine SGOT and the SGPT, the positivity rates are very, very high. So both the enzymes always go up in tandem. But one thing to remember is the SGPT, half-life of SGPT is very, very prolonged. So it takes a very long time for the SGPT to come down. The SGOT will go up and come down very, very quickly. But I think both of them both of them go up in alcoholic liver disease and then slowly it will drop. The SGOT will drop very quickly. SGPT will take some time to drop, but both of them will go up. Domino transplant is the next question. Can I answer that?
Right. Thank you, sir. We have Shashank asking, sorry. Is that, yeah. Sorry for the interruption, sir. We have Shashank asking, what's the domino type of transplantation and what are its risks?
In fact, in the type of transplantation, I did put domino transplant, but I did not mention anything about domino because I think it'll take some time to explain what a domino is. So you know what a domino effect is. One on the other, and then this goes there. So I'm going to give you an example. So I have one patient with familial amyloid polyneuropathy. Okay, that's called FAP. That's a condition where there's one small enzyme deficiency in that liver, and that would cause the nerves to degenerate. Okay, patients present with vague pain all over the body. And classically, when you biopsy a nerve, you will find an FAP deficiency. Okay, so this comes from the enzyme comes from the liver. The metabolism does not happen in that liver for that particular enzyme. Now, the patient presents at the age of about 40 or 50. So it's taken 50 years for an FAP patient to develop that symptom. But that liver is a completely normal liver. Okay, it is a non-cirrhotic liver. Otherwise, it's completely healthy, healthily functioning. Okay, so but this fellow needs a transplant, because what happens in FAP is that if it is not attended to, it will affect the myocardium over a period of time, and the patient will die of cardiac failure for sure. Okay, so the liver should be transplanted when someone's got an FAP. So this fellow, when this fellow needs a transplant, so cadaveric liver comes in. Okay, so you take this liver out and you put this new liver in. Okay, now this liver is again, it's a normal liver, but it's called the FAP deficiency. Okay, but we know that it's going to take many years for it to develop in another patient. So what we do, we put this into another cirrhotic patient. Okay, so when you have one liver and then one guy with some congenital abnormality or congenital deficiency, you take this in, put this in, you then put this into another patient. So with one liver, you can transplant two patients. So this is called a domino transplantation. Very rare, very few is coming. I've done a domino. It takes a long time to do all these. It takes about 18 to 24 hours for us to complete the surgery itself. But it's quite rewarding because two patients are saved in this process.
Then someone's asking, what could be the possible complications after liver transplantation surgery, and can certain proteins in the blood contribute to the organ rejection?
Complications of transplant, you can talk about that for an hour together actually. So immediate transplant, I'll just be very brief. Immediate transplant, immediate complication is primary non-function of that liver. It's called PNF, where the liver just completely does not work at all. The patient probably dies on the table or dies the following day. Okay, in the first week, what can happen is you can have all technical complications. Okay, your hepatic artery thrombosis, your portal vein thrombosis, your bleeding, your kinking of the hepatic veins, so on and so forth. So bile duct leaks, So all these. So first week, predominantly technical complications happen, right? From the 5th to the 7th week, what happens is the immunological 5th through the 7th day, immunological complications set in, i.e. rejection. Okay, because the body then understands that this liver is new and it starts rejecting the liver. Because that is when, of course, patients will be on immune suppression right from day 1, but the rejection classically happens from day 7. Okay, that's called the acute rejection. Right. Once we tide over this 2-3 weeks of once we tide over the first week, very rarely after that you get any technical problems. Okay, as in portal vein thrombosis or hepatic vein thrombosis or bile duct leaks. Okay, of course, bleeding, infection being common for any kind of surgery. Once you cross the first week, most of the time nothing major happens. Now, after the first week, as I said, rejection can happen anytime. Acute rejection can happen anytime. But we always keep on top of the immune suppression. We monitor them very, very closely. And if there's any alteration in the SGOT-PT, then we increase the immune suppression. Okay. Long-term complications, chronic rejection is a problem. Of course, again, if there's a chronic rejection, we increase the immune suppression. If they respond to that, then it's good. Otherwise, all these people will need to retransplant. The other problems which you should know is the problems with immune suppression. Immune suppression is a double-edged sword. Okay? So one, it can cause diabetes. 20% of them can have renal failure. About 10% can form skin cancers, throat cancers, so on and so forth. Okay, so roughly these are the small complications: immediate complications, post-op, immediate post-op, and the long-term complications. Of course, there are lots of various other things. I don't want to go into the minor details. Next.
Right. Samarth is asking, sir, is transplantation a good option in a patient with alcoholic cirrhosis with cardiac complications?
So, of course, as I said, any transplant which we do, they undergo very rigorous cardiac assessment. We stress the heart, we do a stress volume or a bitumen stress echo. In diabetics, we make sure that the coronary angiograms are normal. Okay, but very rarely cardiomyopathy happens in patients with alcoholic cirrhosis. So if my cardiologist is going to tell me that this is a high risk patient and there's a chance of the heart stopping during the transplant process, obviously we would not transplant any of these patients. So as I said earlier, in the assessment, I will only transplant patients who's got an extremely good cardiac reserve. Of course, I've been involved in transplanting when doing a bypass and a transplant at the same time. You know that, I mean, I was involved in that twice, and twice it was a disaster. I don't think I'm going to do that ever again in my life. But never ever we should transplant patients with poor cardiac function, because transplant is such a huge process. You know, so much fluid shifts, so much fluctuations of blood pressure, so much fluctuations of the heart rate, and the heart cannot tolerate any of that. Then obviously, obviously we will not transplant any of these patients.
Okay, sir. And the last question for today would be, is there any weight criteria of donor's liver for liver transplant surgery?
Weight criteria of donor's liver. I mean, of course, I didn't, as it is, this talk was too long, so I didn't go into all the donor criteria. But in more than the donor criteria, okay, the recipient is important, as in, so how much does the recipient need is the question. So as an unwritten rule, the recipient needs 1% of his body weight. Okay, so if someone's 80 kilograms, then he would need at least 800 grams of liver. Okay, that is what the body needs. Of course, we can go down to 0.8%, which is, if it's 80, means it's 640 to 650 grams. That's not a problem. Okay, so that is what the recipient needs. In the donor, what is important is the amount of liver which we leave behind. Okay, if the liver is healthy, the donor liver is very healthy, then we can go up to 30%. I know, inadvertently, I've left 27% and the patient developed a bit of jaundice. And then, of course, the donor recovered. But I think my cutoff today would be about 30%. And that is what any surgeon would do today anywhere in the world. So residual liver volume needs to be 30%. The donor needs about 0.8 to 1% of his total body volume.
Thank you so much, sir. Nakshatra, do you have a question? I can talk. Thank you so much, sir. Those were absolutely brilliant. I think all of our questions got answered. I just wanted to say one thing for everybody who's been messaging me that they want to see the video. We will be sharing that video on the WhatsApp group. So if you could share the link for that video, that'd be really great. Before we end this meeting, I request everyone to please switch on your webcam so that we can click a photograph with everyone. Everyone, please switch on your webcams. It's nice to see a lot of familiar faces from day one.
Super, guys.
Just give me 1 minute. We have lots of participants. Everyone switch on their webcams, please. So, all right, we're done. You can stop smiling or keep smiling. Thank you so much. Keep smiling. Absolutely. Thank you so much, sir. This was an absolutely incredible session. I think most of us really enjoyed those clinical images, and we'd love to see the video as well. I'll stop